Welcome, everybody. So this is just to continue and finalize the lecture started Thursday on the historical and policy perspective regarding healthcare delivery in America. We started off the class watching a trailer of the movie Sicko by Michael Moore, who we know now is a very liberal person and has a very liberal persona. And if you remember from your studies of political science and government, the liberal viewpoint is usually with the Democratic Party, in contrast to very conservative ideologies, that is mainly a Republican perspective. So I will try to make sure that this class is very balanced in terms of perspective. We all know that that's why the United States is what it is. And we have this 2 or sometimes 3-party system. That is arguably one of the best governments, and the way that it's administered and the way that it's governed is one of the best in the world because of our democracy. In this course, one of the main questions we do ask is, how is the healthcare system doing? In the past, we have not done a very good job, and even up to now, we have not done a good job of understanding what is performance, and how do we measure it, and how do we be transparent about it. And with healthcare reform, the Affordable Care Act, it's kind of a game changer in terms of not only measuring performance, but being transparent about the performance of the healthcare system, both from a public standpoint and a private standpoint. We can argue that in the public sector, specifically with the provisions of Medicare and Medicaid, we have access to that data. However, the private industry has not been as transparent as they should be. And so that is one of the main tenets that the Affordable Care Act and healthcare reform is trying to do. So we'll also look at, again, how inputs, outcomes, and everything in between, which are the processes, will be measured and evaluated. One of the aspects that healthcare reform and Affordable Care Act is trying to address is the uninsured. Many countries have a universal insurance system where everybody in a country, for example, Cuba, has access to healthcare. But in America, technically, not everybody has access to healthcare, or at least insurance. And so these upcoming slides were just to kind of gauge, inform you of the data with respect to uninsured. So the census does an excellent report of demonstrating the information on income, poverty, and health insurance coverage in the United States. You can just Google this or put the link at the very bottom here on the left. You can get access to this information. And in the United States, the number of uninsured was approximately 48 million. The uninsured rate translates to about 15.4% in 2002. And you can see how this fluctuated between in the 80s and up to now. This is data on the uninsured rates in children by poverty, household income, age, race, Hispanic origin, and nativity. And we demonstrated that there are some disparities between children who are poor and those who are not, and that is kind of logical to assume. And also it's provided here in this data that the children in poverty are more likely to be uninsured. Children who are more poor tend to be also uninsured. Age, not so much. race, you can see that the Hispanic race tend to be more uninsured, as well as those who are non-citizen. Female households with no husband present are about twice as likely to be poor. So one of the points that, again, the Affordable Care Act is trying to protect, hence the word, the Patient and Protection Affordable Care Act. That is the complete name of the Affordable Care Act. Not only is it trying to protect children, but also females who could be disproportionately be more vulnerable. So what are the extent and consequences of being uninsured and underinsured in the US? We know that when we are healthy and young and we don't have chronic diseases or as many emergency problems as the elderly, we tend not to pay for health insurance when we're younger. We don't need it. Sometimes it's because it costs too much. And we know that the poor or near poor individuals who don't qualify for Medicaid, because they don't have the capital, they don't have the income that's devoted to healthcare, they need it for other essential things, or their other priorities are above that of healthcare and insurance. They will choose not to purchase it. The other aspect is that persons or employees of small companies, although they have substantial income, they may not purchase health insurance, again, because it is more expensive. It costs too much. They must pay a higher premium, especially when we compare that to larger organizations where they have kind of this economies of scale. They have more buying power. So all else being equal, for a large company, it's cheaper for them to buy health insurance versus a small company. And the Affordable Care Act is trying to address these issues by providing incentives as well as tax breaks to smaller organizations so that they can purchase health insurance for their employees. We mentioned cost already in the previous slide as a reason for not having health insurance. So again, validated here in the National Health Interview Survey, although a bit dated, is still relevant discussion as we talk about historical reasons for not having healthcare, that it costs too much. And then a few other reasons as mentioned, from losing a job, the employer may not have insurance because they're a small company of 10 or less people. Your Medicaid benefits may have stopped because you make too much money. You might be ineligible because you have got older or you've left school. And then you may have change in marital status where you may have been covered under a spouse's insurance. Now you may not. This is data from the Organizations for Economic Cooperation and Development. So a global organization that tracks outcomes related to economics, policy, as well as healthcare. And we have demonstrated here that the United States, although they have one of the highest spending per capita, their life expectancy is not as good. It's not commensurate with their amount of spending. So ideally that you want to, from a quality standpoint, you want to spend the least and have your life expectancy rise. And then conversely, you don't want to be in a situation where you're spending a lot of money, but your outcomes aren't improving. So the US spends the third highest per capita on healthcare, yet life expectancy is 7th from the bottom. we mentioned the paradox of the U.S. healthcare system. So we have some of the highest standards with regards to professionalism, facility licensures, certifications at the state level, at the federal level. There's a lot of regulation for somebody to be certified, whether they be physician, pharmacist, nurse, or otherwise. Moreover, we also have the capabilities to have and lead in drug development, in medical device testing and development. So we are very advanced, and we have a lot of technology that's available to us. And you might argue it's too available, and that's one reason why there's this uncontrolled spending. As noted in the OECD data, we have some of the highest expenditure per capita, meaning that approximately we spend 16% of our GDP towards healthcare system. So the idea is to control that percentage, to make it lower, or sometimes we call it try to bend that cost curve. We know that the prices in the United States are astronomical, and it's a relative term, especially relative to other countries. So somehow in the United States, compared to other states, we are paying a higher price for the same drug versus a country who may pay for it much cheaper, much less, all else being equal. So that price in and of itself is a focus of healthcare reform. And one of the ways to deal with prices is to have more negotiation, to be more transparent. And as an example, Medicare is now making sure that they are purchasing materials for patients, that there is a kind of an open bidding process between manufacturers so that the government can get the cheapest price for a particular product, especially in durable medical equipment, DME, such as wheelchairs, walkers, and those kinds of devices. So we know that the healthcare system is fragmented with respect to regulation, financing, and delivery. Again, a focus of the Affordable Care Act. We have a high rate of error. More data points to 100,000 deaths per year are due to medical errors alone. We have issues, we have cultural issues, so socioeconomic and racial disparities are things that we need to address in healthcare reform. And of course, why do we have healthcare reform? It's one of the reasons why is that not everyone has adequate health insurance. So how much money does the US spend on healthcare? We know that it's growing, right? So since the 60s, you can see that top line being a steeper curve versus all other spending. So $2 trillion per year, as mentioned, 16% of the GDP, or $7,000 per person. And if this keeps going in 2020, which is only a couple years away, the percent spending of GDP will rise to 20%. And then you can see how in 2035, that's going to be well over 35% if we do nothing. With healthcare reform, the provisions and mandates is trying to bend the cost curve. It's trying to bend it so that it can flatline, or at least be on par with all other spending. Again, showing you that the insurance premiums, the cost of insurance, increases at a faster rate than overall inflation or workers' earnings, which is depicted by 28 and 38%, whereas healthcare or at least let's just look at health insurance premiums, the cost of getting health insurance has increased at quite a bit faster rate. History is important so that we can learn from the past to make us make better decisions for the future. Starting in the colonial era, we know that malnutrition, infection, disease was prevalent. Not only Europeans, but others who immigrated here from other continents also brought on new diseases. Because the US was relatively a young country, professionals in medicine and pharmacy, there was a lack of them as well as any facilities for that matter. And we know that public health, population health, there wasn't agencies, there weren't cities, there weren't departments of public health to help with any kind of community or individual health caretaking for the sick. As far as patients and the population in the 1800s, we know that there was this big gap between those who were in urban versus rural areas. We know that rural areas had fewer professionals. Urban areas exhibited socioeconomic difference in access to care, meaning that those who were well off, who had money, who had resources, could find a medical professional to get some kind of help or treatment. And as far as sanitation and pollution in these areas, they obviously contributed to infectious disease. And we know that infectious disease during this time was one of the primary contributors of death. So as far as what were some of the treatments, what were some of the medicines, so many treatments were prepared by pharmacists or physicians, or both. Some physicians were pharmacists, some pharmacists were physicians. And of course, this was for the most part not regulated, right? There wasn't any regulation as far as training goes with pharmacists. Training goes as far as physicians. They were both starting at this time approximately, and in particular through apprenticeship. Most pharmacists who were quote-unquote pharmacists were trained through apprenticeship. And then we'll talk more about schooling as time evolves. And of course, with pharmacists, they started to create medicines. And because physicians would consult a pharmacist for a particular medicine, pharmacists knew that this was an economic and entrepreneurial opportunity to start to make and manufacture medicines and drugs. And so that therefore this whole era of mass generation of medicines started at this time. And as you can imagine, because this was an opportunity as population grew, this also became problematic, and pretty soon it was pointed out that these medicines may not be safe, and then therefore this started to lead to certain regulations of medicines. For practitioners at this time to treat people, they had several disease theories to utilize to determine the cause, for example, of a disease or a disorder. So miasma meant bad air, that it was something in the environment, or it could have been something very culturally related with respect to religiosity, so some kind of supernatural force, or you may have been sick as a result of having sinned. And then kind of more scientific is germ theory. So not yet common, but obviously evolved as infectious disease was becoming noticed under the microscope, quote unquote. And there were values and therapeutics and various practitioners who were now starting to be the masters of health, for example. So one person is Galen, who introduced drugs, and then this idea, another notion of health, which is humorism, which is that because the body is interconnected, we know that certain diseases that affects one organ can ultimately impact another organ. So that's a picture of Galen there on the right. And then above that is a skull with a bore through it. And sometimes this was a method called trepanning or trepanization, where somebody had some kind of brain illness or a mind illness, or somebody had some kind of psychiatric illness, that one way to treat this person was to bore a hole through their head so as to perhaps let the evil spirits out. So Galen on humorism. This is a quote by Charles Rosenberg. And yeah, by now we're like, yeah, this is kind of a no-brainer, but in Galen's time, for him to be an authority of understanding how the body works and how there's a balance and how there's kind of an input and output of the body processes, it was kind of a revolutionary at that time. More about Galen. So compounds and preparations for healing date to the time before Christ. He was a Greek physician and introduced the concept of body humors. He advocated for the use of polypharmacy. So even though Galen lived, again, way before the colonial times, his impact was certainly important. Even during this era, the separation of physicians and pharmacists started to occur. As pharmacists started to focus on patient diagnosing, you can imagine that the medical profession, the physicians, would try to protect their turf. And so this separation, even at this time period, started to occur between pharmacists and physicians, although there were many physicians and pharmacists who practiced both. The idea of fee-for-service, where a professional will get remunerated, would get paid as a result of providing a said service, was an important factor, an economic and a financial incentive for pharmacists to also be in the business of medicine. So physicians dispense drugs in the office and home visits, while pharmacists open stores to fill prescriptions for patients of physicians and to compound drugs requested by their customers. So obviously there was this symbiotic relationship that had occurred, but at the same time, pharmacists also they had seen this economic opportunity. This is just a picture at the bottom of Dr. William Proctor, who is considered the father of pharmacy. There are two types of practitioners at this time. So the orthodox physician and the sectarian. The orthodox, also known as the allopathic or regular physician, so some medical education and apprenticeship, and then they mainly practice quote-unquote heroic medicine. So this consisted mainly of depletive measures, so to use drugs or procedures which cause a visible change in secretion excretion. So that picture of that I showed with the bore or the hole in the skull or trepanization could be an example of depletive measures. Also, strengthening measures. This is where tonics and astringents were often used by, and especially used by the lay public. So sectarians, these are more alternative practices. So at this time period, so homeopathy or folk medicine, cure establishments. So these are practitioners who didn't have any formal training whatsoever compared to their counterparts, but at the same time, there was a movement of some of these homeopathic alternatives. So post-Civil War, increase in the number of hospitals. We now have increasing in paying clients. New techniques, not just in aseptic and antiseptic techniques, but various other pharmacological, clinical treatments that are being developed after the war. You can imagine that after this war, the plethora and variety of injuries, both mental, psychological, physical, emotional, caused many changes in medicine. What I should have here also is even post-World War I changes in the impact of hospitals. The Hill-Burton Act is a federal act that increased the federal funding of hospitals. It gave quite a bit of money to develop new hospitals, and so it increased the availability of hospital beds. We'll talk more about the importance of the Hill-Burton Act in the hospital lecture. So in the 1900s, medical training still varied widely for physicians, pharmacists, and others. Again, this is a picture from, if you want to look at the history of pharmacy, Washington State University College of Pharmacy has an excellent website that shows the development of pharmacy. One important person in healthcare, not just in pharmacy, but most definitely in medical education in general, is Dr. Abraham Flexner. He was charged by the federal government to lead an analysis to provide a report of the healthcare system in America here in right around the 1900s. In particular, this report was in 1910. So it was titled Medical Education in the United States and Canada, a report to the Carnegie Foundation for the Advancement of Teaching by Abraham Flexner. So what were some of the results of the Flexner report? Well, he talked about that medical education is very truncated, it is very unregulated, and as a result, there were many medical schools that had closed, that there was this lack of standardization, so the regulation of standards and an increase in accreditation rose for medical schools. And interestingly enough, there was a decrease in student diversity. So increasing focus on the professionalism was another aspect of the report. And in pharmacy, this impacted pharmacy to a great extent. Pharmacy education standards escalated from 2 to 4 years, and then this concept of pharmaceutical care started to be established. Dr. Flexner, although great for healthcare, initially for the practice of pharmacy was not very favorable towards the practice of pharmacy. But that's also in a good sense, in that he catalyzed, he was one of the main catalysts to professionalize pharmacy. As our population started to increase and different professions started to mature, various government regulations and interventions in healthcare with these acts became very important and started to guide healthcare policy in America. So in 1906, the Pure Food and Drug Act, so this is the first federal law that regulated food and drugs. In 1930, the National Institutes of Health was established. This is where the focus of research, biomedical research, and everything related to pharmaceutical development, to various other clinical developments, are researched, are appropriated by the agencies within the Institute to give funding to, for example, universities such as Concordia. In 1935, the Social Security Act was established. In 1938, the Food, Drug, and Cosmetic Act, so it gives authority to U.S. Food and Drug Administration to oversee the safety of food, drugs, and cosmetics. We mentioned previously about the Hill-Burton Act and its impact on facilities, in particular hospitals. In 1951, there was this Durham-Humphrey Act. It was to regulate prescription versus over-the-counter drugs. In 1965, the Medicare and Medicaid, these are officially designated as Title 8 and 9 of the Social Security Act, so that it's not necessarily called Medicare and Medicaid Act, but officially is designated as Title 8 and 9 of the Social Security Act, respectively. In 1996, there was also the Health Insurance and Portability and Accountability Act, otherwise known as HIPAA. So these are just several. There are many more, and within these acts, you can imagine the sometimes hundreds of provisions within one act to regulate a particular profession, to regulate a particular industry. In the first half of the 20th century, employers started to realize the importance of keeping their employees healthy. They would become more productive. Business would be better. So providing some kind of health insurance coverage became a top priority for many employers. And from a public standpoint, the federal public health insurance efforts also started to begin at this point. Franklin Delano Roosevelt and in the New Deal kind of looked at the welfare system of America to provide for the most vulnerable in children and in women. But at the same time, they also looked into providing universal healthcare coverage. However, as we come to know it, Medicare and Medicaid did not become enacted till 1965. The maturity from cash payments to third-party payments started to begin. So no need to pay out of pocket if you were covered by your health insurance. It was now a third party that was going to be managing your healthcare as a result of your employer providing some kind of healthcare. So, for example, Blue Cross Blue Shield was one of the very first health insurance institutions in the country. So health insurance in the later half of the century was brought upon by a few other important acts that helped to reform healthcare. As we mentioned previously, Medicare and Medicaid is important in terms of providing coverage for the elderly, and the low income, as well as other vulnerable populations, respectively. The HMO, so the Health Maintenance Organization Act, was enacted to try to control cost as early as this time period in the 70s. That I had talked about capitation or bundled payments versus fee-for-service. This is one way to try to combat cost, was to try to capitate, try to bundle some payments. And with HMOs, that's how the government tried to control certain aspects of escalating costs in this time period, was to have these HMOs. The COBRA Insurance Continuity, so Consolidated Omnibus Budget Reconciliation Act. This act was to protect employees who had to leave a job and for them to continue their insurance coverage months after they had left a job. So in between their two different jobs, COBRA tried to provide coverage in in their interim of trying to find another job. The HIPAA Act, again, which we'll talk about in detail in the health insurance section, which provided not only privacy but other provisions related to portability and accountability. And then the CHIP program, or the State Children's Health Insurance Program of 1997. So this CHIP also dovetails with Medicaid. Whenever we're talking about this vulnerable population, children, sometimes it's a good idea that even though Medicaid is a means-tested program, meaning that you have to qualify as a based on your income, CHIP will provide children certain levels of insurance coverage regardless of the income of the parents. Fast forward to the 21st century. Importantly, as it relates to Medicare, is Part D. So this included many provisions related to medication therapy management and insurance coverage for pharmaceuticals in general. Again, we'll cover this in detail in the Medicare and Medicaid section. And then finally, we've talked about healthcare reform. We've talked about the Affordable Care Act, or more specifically, it is the Patient Protection and Affordable Care Act. You can find these two documents and these two links. The first one is the bill itself, the almost 1,000 page of legislation related to healthcare reform. And then the second bullet being a summary of the provisions of the Affordable Care Act by the Kaiser Foundation. In the new 6th edition textbook, I wanted to make sure that we are on the same page with respect to what the textbook has and what is current with regards to Affordable Care Act provisions. But these are just some of the highlights very broadly with respect to Affordable Care Act provision. So I'm going to read this. This is the last slide, but I do want to read it verbatim in case you're just reading this or listening to me on an audio file. And we'll talk about more of them in detail again as we proceed with this class. So, mandating that Americans obtain at least the minimum amount of health insurance or pay a penalty. Health insurance could be obtained with insurance companies through employers or purchased individually through Medicaid, or for those with incomes too low to purchase insurance through designated federal subsidies. Making changes in health insurance performance activities that included such provisions as stopping the practice of imposing refusal to cover or changing more for pre-existing conditions, ensuring that current insurance plans may be renewed, providing coverage beyond childhood to the age of 26, requiring that insurers justify premium increases of 10% or more before rates can take effect, expansion of the designated preventive services, establishing insurance marketplaces or exchanges on a state basis where individuals and small businesses could purchase health insurance plans. These exchanges were made available through online government websites. States can run the exchanges, and if they don't wish to, instead the federal government may run them. Expanding Medicaid program in order to provide opportunity for more Americans to obtain health insurance. So just kind of a few highlights, certainly not exhaustive, but gives you an idea of healthcare reform as it is in 2016.